Bahiyah, and she is currently a trainee in reproductive medicine. So please welcome Dr. Rahilah.
Okay, Assalamualaikum and a very good afternoon. Thank you, Dr. Kaur, for the introduction. So thank you for staying after lunch. So I will proceed with my presentation. I will cover a topic that is fairly important in infertility, which is male infertility. So this is the contents of my topic. First, we will look at the introduction, whereby we will look at the epidemiology and also incidence of male infertility. Next, we will go to some basics on spermatogenesis and how do we approach a patient with male infertility, looking at the history taking, physical examination, and what are the investigations that we normally do for this group of patients. And last but not least, we will look at the general brief management of patients with male infertility. So on epidemiology, the incidence of male infertility varies according to regions, which is about 15 to 60%. And there is more cases reported in the Middle East and African countries. So the number of cases, incidence is actually very conflicting due to various reasons, mainly due to underreporting of cases. So the factor that might affect the reported cases as number one, male infertility has not been considered as a disease. Number two, the most important thing is the social stigma, whereby they are worried of society's perception on the male infertility. And also the last but not least is the lack in assessment because majority of the doctors are focusing on the female causes of infertility. So we look at the basic physiology about the normal sperm production. So this is anatomy of a sperm. You have a head, middle piece, and the tail of a sperm. So head contains the nucleus and also acrosome, which is the enzyme, which contains the enzyme that is important during fertilization. So the middle piece will contain mitochondria, which will give the energy for the sperm to swim. And the longest part of the sperm is the tail, which will aid in swimming process towards the oocytes. So the important function of sperm is basically to swim towards the oocyte to deliver two important subcellular structure, which is the genetic material that is contained in the nucleus. And number two is the centrioles, which is important in the arrangement of the cytoskeleton microtubules. So when we talk about the seminal fluid analysis, we know that the normal volume is about 1.5 to 2 mils, but the content of the seminal fluid analysis, majority of it comes from the secretory glands, and only 2 to 5% of the content actually is made up of sperms. So during ejaculatory process, what happens is that sperm that is stored in the epididymis will get transported through the vas deferens. So they will travel to the first structure, which is the seminal vesicles, which contain alkaline fluid rich in fructose, amino acids, citrate, and prostaglandins. And this will give about 67 to 75% of the secretions in the seminal fluid. Then you will travel through the ejaculatory duct and prostatic urethra. This will give you another 25 to 35% of the secretion, which is mainly made of proteolytic enzyme, citric acid, acid phosphatase, PSA, and also zinc. And later on, all this fluid will travel through the penile urethra and ejaculated through the penis. So when we talk about the regulation of spermatogenesis, first we must look at the hormonal regulation, which is the hypothalamus, pituitary, and testicular axis. So this is a classic negative feedback loop arrangement, whereby you have a secretion of GnRH from the hypothalamus, which will give you a signal to the anterior pituitary to release FSH and LH. So both will have a distinct function. The first hormone, which is the LH, will signal the Leydig cells to produce testosterone, and the local or intratesticular testosterone is important, which will play a part in the spermatogenesis process as well. So the testosterone will subsequently be converted into two important metabolites, which is the estradiol and also dihydrotestosterone, which is the active form of testosterone. Whereby the FSH will cause a direct stimulation on the Sertoli cells, whereby it will regulate the gene expression and protein regulation that is important in the spermatogenesis process. And another hormone that is secreted by the Sertoli cells is the inhibin, which will give you a negative feedback on both the anterior pituitary and also hypothalamus. So when you have a higher level of testosterone, for example, patients that are taking anabolic drugs that containing testosterone, this will give a negative feedback to the anterior pituitary and hypothalamus as well. So when we talk about the spermatogenesis process, a whole spermatogenesis process takes about 64 days. So it starts with primordial germ cells that being converted into spermatogonium. So they will still have the same number of chromosome, and when the spermatogonium subsequently produce spermatocytes, and it will undergo the first meiotic divisions that will give you secondary spermatocytes, and meiotic division 2 will give a formation of spermatids. And these spermatids will undergo process of spermiogenesis, which will give you a mature spermatozoa. And what happens is that the mature spermatozoa will be released inside the lumen, into the lumen, and they will travel into the epididymis for the storage process. And this whole journey from the lumen of the microtubules in the testes to the epididymis will take about 12 days. So when we look at the causes of male infertility, we can broadly divide the causes into three important things. The commonest would be primary testicular defects in spermatogenesis, where it consists about 70 to 80% of causes at most of the times. The second important one is the endocrine and systemic disorders with hypogonadotropic hypogonadism, which accounts for 5 to 15%. And the other component is sperm transport disorders, which is about 2 to 5%. So majority of the patients that come to infertility clinic, basically they are having idiopathic dyspermatogenesis, meaning that we can't find any obvious cause of the abnormal sperm production. And the other reasons for testicular defects in spermatogenesis can be broadly divided into congenital disorders. Example would include Klinefelter syndrome, which the patient will typically present with hypogonadotropic hypogonadism, azoospermia, and a small testis. And it affects about 1 in 500 to 1 in 700 of males. And there will be patients with severe oligospermia, usually in a milder form of Klinefelter syndrome. Patients with cryptorchidism, which means the failure descent of the testis, will also have some defects in spermatogenesis. Another congenital disorders include androgen insensitivity syndrome, 5-alpha reductase syndrome, estrogen receptor or synthesis disorders. For acquired diseases, something that we need to bear in mind is varicocele. So that's why it's very important to examine the genital area, whereby you can pick up varicoceles. Severe form of varicoceles, which is grade 3 and grade 4, might impair spermatogenesis. Infection, mumps have been reported as the commonest cause of abnormal spermatogenesis, with incidence of 15 to 25%. And gonorrhea and chlamydia will put the patient at risk of having epididymoorchitis. Environmental toxins, for example, cadmium, lead, mercury, phytoestrogens, and hyperthermia. So for smokers, what they have is that they have abnormal level of cadmium and lead in their blood. So what happens is that they will have a significant reduction in spermatogenesis by 23% reduction in sperm count and 13% reduction in sperm motility and also morphology. Besides, it can also lead to a high DNA fragmentation in the sperm, which will subsequently impair fertilization, embryo development, and also implantation. So trauma to the testes, testicular torsions, and also any immunological disorders, for example, the presence of anti-sperm antibodies, might also give rise to the abnormal sperm production. Genetic causes, for example, Y chromosome microdeletion, whereby the patient typically presents as azoospermia, can be picked up by doing chromosomal studies. Autosomal and X chromosome defects and also mutations will also cause severe sperm morphology. So for the endocrine group, congenital disorders included Kallmann syndrome. Usually the commonest that we encounter is idiopathic hypogonadotropic hypogonadism. When this group of patients have associated anosmia, so these are known as Kallmann syndrome. So for patients with thalassemia requiring regular blood transfusion when they have iron overload in the pituitary, so this typically will give you a low level of FSH and LH, which will subsequently impair spermatogenesis. So in acquired conditions such as tumors, infiltrative disorders, surgeries and vascular lesions, they can also get low production of FSH and LH. Drugs, for example, patients they are taking exogenous androgens, opioids, psychotropic drugs, and also GnRH agonists. Systemic illnesses for patients with end-stage renal failure, sickle cell disease, nutritional deficiencies, and what we are commonly seeing now is morbid obesity. So how does morbid obesity cause hypogonadotropic hypogonadism? Is that because of the high fat level, so there will be more production of estrogen. So this estrogen will give negative feedback on the hypothalamus and also pituitary. And at the same time, when you have a high level of fat tissues, they will also produce leptin, which will produce high level of oxidative stress, which will cause impairment of spermatogenesis. So sperm transport disorders accounts about 2 to 5% cause of abnormal sperm production, which can be caused by epididymal dysfunction due to drugs or infection. Another congenital disorders that we have to look for is the congenital absence of vas deferens, usually associated with cystic fibrosis, which is not commonly encountered in our country, seminal vesicles and prostate problems, and also ejaculatory duct disorders. So how do we approach this group of patients? History taking is very important. So when we talk about infertility history, we must know the age of the partner, the duration of infertility, whether they had any previous conception, whether they went for any evaluation or the previous treatment that they had. Sexual history, what about the history of maintaining erection, ejaculation, and the frequency of sexual intercourse. Childhood and development, the puberty onset, whether there's any history of cryptorchidism, hernia, and also testicular trauma, any history of testicular torsion, infections, for example, mumps and TB, personal history, especially patients with diabetes mellitus, poorly controlled diabetes mellitus will give you ejaculatory disorders, hypertension, STIs, TB, and also viral infection. Previous surgeries to the genital area and also retroperitoneal and pelvic surgery, bariatric surgery for patients with morbid obesity, bladder neck surgery and transurethral resection might put the patient at risk of having retrograde ejaculation. The gonadotoxin exposure, there are certain drugs that is associated with abnormal spermatogenesis. There are also a group of drugs that will give you feedback to the hypothalamus and pituitary axis, such as exogenous drug, and high temperature, electromagnetic energy, and radiation. Family history, cystic fibrosis, if the patient is having respiratory infections, endocrine diseases, and also infertility history in the family. And current health issues, whether the patient is having anosmia that might suggest Kallmann syndrome, galactorrhea, which can be induced by drugs or any pituitary macroadenoma, and also obesity. So these are the list of drugs that can impair male fertility. Drugs such as sulfasalazine, MTX, nitrofurantoin, colchicine, and chemotherapy will directly cause impairment in spermatogenesis. Pituitary suppression, as I told before, because of exogenous administration, usually drugs containing testosterone and GnRH analog. Drugs with anti-androgenic effects such as cimetidine and spironolactone. Drugs that can cause ejaculation failure include alpha blockers, antidepressant, and also phenothiazine. And beta blockers, thiazides, and metoclopramide can put the patient at risk of erectile dysfunction. So how do we examine this patient? The first important thing is to look at the general examination, the masculinization features of the patient, the build of the patient, the hair distribution. The skin, if the patient is having thalassemia requiring regular transfusion, you can see hyperpigmentation of the skin, which might indicate iron overload. Patient with Cushing syndromes will have truncal obesity, easy bruises, and also if patient is having testosterone deficiency, you will see features of feminization. BMI is very important, especially if the patient is obese. So for external genitalia, you must examine the scrotum, the penis, the size of the testis, and also epididymis. And when we are suspecting varicocele, what you can do is you can ask the patient to do a Valsalva maneuver if their varicocele is not really apparent. And when we examine the testicular volume, what we can use is what we call as oxidometer. comparing the testicular size to the oxidometer, and the normal testicular volume ranges from 15 to 25 mils with a normal testicular length which is about 4 to 5 centimeters. So basic investigations include seminal fluid analysis, specialized seminal fluid analysis, endocrine testing, and also genetic testing. So the basic thing that we can do is seminal fluid analysis. We look at the seminal volume and pH. So there are two components we will look at, which is the macroscopy assessment and also microscopy assessment. So how do we instruct the patient to collect the seminal fluid? We ask them to from sexual abstinence, usually about 2 to 3 days. And the seminal fluid is collected via masturbation. And if it's not possible, the patient is advised to use condoms without chemical additives. And the sample should be delivered to the lab within 1 hour of collection. And if you have an abnormal sample, so you need to get another sample, which is at least 2 months apart, because the whole spermatogenesis process, as I said, takes about 64 days. So this is the macroscopic elements while assessing the seminal fluid. First, we look at the appearance of the seminal fluid, which should be whitish to grey. If you have a yellow discoloration, this might suggest urine or even jaundice. If the seminal fluid appears as pink, reddish or brown, this might suggest presence of RBCs. And the seminal fluid should be able to liquefy within 15 to 30 minutes after collections. If it takes more than 1 hour, this should be recorded. It could be a sign of prostatic infection and lack of prostatic proteases. It should be smooth and watery. If you have a seminal fluid specimen that appeared to be thick with long threads, meaning that it is abnormal, and high viscosity may impair sperm movement. What about the pH? pH should be, the lowest should be about 7.2. Usually it's about 7.2 to 7.8. If it's lower than 7 with low volume and sperm, this might suggest CAVD or ejaculatory duct obstruction. So we have the WHO values of SFA reference. So what are the most important components? So the likelihood of infertility is increased with abnormalities in any of the 3 parameters, which is the count, motility, and morphology. So the values has been changing from year to year, and the latest has been published in 2010. So the lowest sperm concentration is about 15 million per mil, with total motility of 40% and progressive motility about 32%, which is taking into rapidly progressive sperm and also slow or sluggish progressive motility. And the morphology should be lowest is about 4%. So what about the other test, which is known as specialized sperm test? It is not routinely done. The first one is sperm autoantibodies, which is present in about 4 to 8% of subfertile men. So what we can see is there will be agglutination, whereby the immotile sperm will stick to each other. It is suggestive but not always conclusive of immunological fertility. So how do we test it? By looking at the immunobid test, which detects sperm surface antibodies, and also MAR, mixed antiglobulin reaction. So semen biochemistry is rarely used in clinical practice. We look at the level of fructose, which is the marker of seminal fluid function. If it's low or undetectable, this is suggestive of CAVD and also ejaculatory duct obstruction. Seminal fluid culture is indicated when the samples contain inflammatory cells. Result is usually not diagnostic, and precautions so that there is risk of contamination. Sperm function test, if it's done routinely, is impractical and costly, and it can be done for patients where the standard semen analysis is normal or near normal. And computers-aided sperm analysis, which have been utilized since 1980s, basically wanted to look at the motility of the sperm. So abnormal sperm terminology, aspermia means there is no semen volume. Hypospermia, when the volume is less than 1.5. Hyperspermia, when the volume is more than 6 mils. Exospermia means there is no spermatozoa in semen. Oligospermia, when the count is less than 15 million per mil. Polyzoospermia, when the concentration is more than 200 million per mil. Astenospermia, meaning that there is abnormality in the motility, less than 40% in total motility or less than 32% in grade A plus B. Teratozoospermia, when you have less than 4% of normal sperms. Leucospermia means presence of leukocytes more than 1 million per mil. Necrozoospermia, you have sperm, but all the sperms are not moving, or we call it as dead sperm. And oligoastenoteratozoospermia, abnormal in the 3 parameters, which is the count, motility, and also morphology. So this is how it looks like, the normal sperm count versus oligospermia. This is the example of abnormal sperms. You can have a small head sperm, large head, 2 heads, abnormal tails, and so on. So another thing that we will sometime encounter is retrograde ejaculation. So what happens is during ejaculation process, so instead of being transported into the penile urethra, the sperm travels backward into the bladder. So there are a few causes. Number one is neurogenic, which is seen in patients with spinal cord injuries. In uncontrolled DM, this is what we commonly see with cases of autonomic neuropathy. Pharmacology, patients who are taking antihypertensive, antipsychotics, and antidepressants. Bladder neck incompetence in cases of congenital defects of hemitrigon, bladder exstrophy, and prostatectomy, and also in cases of strictures and urethral valves. So when we talk about endocrine testing, it is usually intended for patients with severe oligospermia or azoospermic patients. So 2 important hormones that we are looking at is the pituitary hormone, which includes the FSH and LH, and also the testicular hormone, which is the testosterone. So if you have a combination of low FSH, LH, and testosterone, this means that the patient is having hypogonadotropic hypogonadism. And majority patients with abnormal spermatogenesis will have a normal level of hormones. And testicular failure, usually you either have a normal or low testosterone volume with high FSH and LH. So another test that is more sensitive to look for primary testicular failure is inhibin B. So what about genetic testing? The commonest that we can see is Y chromosome and related defects. So we have, this is a long arm of Y chromosome. So you have 3 areas of AZF, which is the azoospermic factors. So deletion of area A and B will give you severe spermatogenesis defects and usually azoospermia. So if you take biopsy in this group of patients, what you can see is just Sertoli cells without any germ cells in the biopsy tissue. So if the patient is having deletion at the area of C, usually the patient will be having some number of sperms or oligospermia. And autosomal and X chromosome defects include Kalman syndrome and Kennedy syndrome. And patient with Klinefelter syndrome, as I said earlier, they usually have an extra X chromosome. So again, the reason that we ask for genetic testing is there'll be some mild form of Klinefelter will present with severe oligospermia. So imaging, if you want to see the testicular size or you want to grade the varicocele, so this is how it looks like when a patient is having testicular tumor, which is an incidental findings on the scan. And how do we manage this group of patients? So there are a few factors to determine our treatment. Number one is the severity of male infertility. Number 2 is the cause of infertility. And again, don't forget about the female partner. So the approach in causes of secondary hypogonadotropic hypogonadism, if the patient is taking any drugs that can cause the abnormal spermatogenesis, you ask them to stop the drugs and repeat the sperm test. And if the patient is having any endocrine disorders, you optimize the patient, which will put the patient in a eugonadism state and improve spermatogenesis. If this fails, then we can use gonadotropin replacement therapy. Most important thing is to ask them to stop smoking. And in patient with morbid obesity, we ask them to reduce weight. So in cases of primary testicular defects, with testicular failure, basically there is no medical treatment, especially if the patient is associated with high level of FSH, more than 14. We know studies have shown that there is no evidence or there'll be very less chance to get sperm, even if you go through surgical retrieval. In normal serum testosterone, LH, and high FSH, if you see high FSH, meaning there is some form of testicular dysfunction. So if we are able to yield some sperm, so we can still proceed with ICSI. And if cases where you have normal testosterone, FSH, and LH, this is what we majority seen in the patient. If there is cases of azoospermia, so this likely a cause of obstruction, azoospermia. So we need to put the patient for surgical sperm retrieval followed by ICSI, and you can still do IUI and ICSI. So if we are able to get sperm in ejaculate, depending on the severity, in mild cases, you can still do IUI. And in severe cases, you proceed with ICSI. This is to decrease the time to conception and live births for couple with male oligospermia due to dyspermatogenesis. And if you can only see spermatids or spermatozoa in testicular biopsies, you proceed with ART. And if there is no sperm, at the moment, there is no available therapy. So sperm transport disorders, if the patient is having ejaculatory dysfunction, for example, erectile dysfunction, usually it's a combined care with the urology team. You can ask the patient to stop smoking, prescribe them with some drugs, for example, sildenafil, obstructive azoospermia, surgical sperm retrieval, and then proceeded with ART. Obstruction of epididymis or ejaculatory duct for patients who underwent vasectomy. So we re-anastomose the vas deferens, and usually it will give you a success depending on duration between vasectomy and reversal procedure. CAVD definitely will need to go through PESA or TC. But the most important thing is the genetic counseling, because there is risk of passing cystic fibrosis to the offspring. And retrograde ejaculation, there are some drugs that can be prescribed, provided that the patient is not having any spinal cord disorders and autonomic dysfunction, followed by IUI and ICSI. So unproven therapies, we are not going to counsel all patients with varicocele to go for surgical intervention, only for grade 3 varicoceles that have been proven to be effective. To treat leucospermia, there are two schools of thoughts, but looking at the evidence, it is said that if you treat the patients with antibiotics, it is failed to demonstrate any benefits. NSAIDs and vitamin E and also fish oil, the results are inconclusive. Some GPs or some practitioners, they tend to give clomid for patients with dyspermatogenesis and normal hormonal profile. Again, this is not proven in studies. What about micronutrients? You know, there are certain elements that are important in providing motility through ATP generation and also increased sperm count. So it has been shown that if the patient is taking micronutrient, it is associated with improved sperm DNA quality, especially in patients who are going for ART treatments. So the last slide will show you the procedure that we do. This is how we do PESA. Basically, this is done under anesthesia. We will puncture the epididymis of the patient, and we will aspirate the fluid and look for sperms under microscope. So the second thing, that if you cannot get sperm from PESA, we proceed with TC, which is the biopsy. We make a small incision on the testes, look at the seminiferous tubules, get some sample and analyze under microscope. So if you are able to get sperm from these two procedures, we either freeze the sperm or we can stimulate the wife and proceed by another round of PESA and TC followed by ICSI. I think that's all. So my take-home message, history taking and physical examination is very important. So basic investigation is sperm analysis, and you need a repeat sample for abnormal results. In cases of mild oligospermia, miles mean from 10 to 15 million, and also acinospermia, what we can do is we can counsel them for IUI. For any count that is less than 10 million, we usually advise them for ICSI. For cases of severe oligospermia and azoospermia, we need additional testing such as endocrine profile and also genetic testing. So for azoospermia, for obstructive causes, we can counsel them for surgical sperm retrieval. And if the patient is having high FSH more than 14, it is very difficult to yield sperm, even we put the patient for TESA or PESA. I think that's all. Thank you.
Okay, thank you very much, Dr. Rahilah. We have 3 questions. The first 2 questions from Muhammad Izhar Hashim. First question is, if a male partner did SFA and come back as azoospermia with borderline volume of 1.6 mils, while other parameters being 0, do we ask him to repeat again or start investigating for another causes such as obstructive or non-obstructive straight away?
Okay, so we know that the sperm production is always fluctuating. All right, so to confirm abnormal production of sperm, you need at least 2 samples. So you need to repeat another sample. If it's still persistent azoospermia, then we proceed with examination. Don't forget about examination to look at the size of testes. That will give you a hint whether it is a case of obstructive azoospermia or testicular failure. So if it still remains azoospermic, then you proceed with endocrine testing. As I said, there is a small percentage of patients with Klinefelter syndrome with severe oligospermia, and majority of them will have azoospermia, and endocrine to look at the level of FSH and LH, and also genetic testing to look for any abnormal chromosome.
Okay, the second question is, what history in patient to suspect retrograde ejaculation, and what investigation to confirm the retrograde ejaculation?
Okay, so patients with retrograde ejaculation, usually what we can find during SFA is the low volume. So if you have a low volume less than 1.5, then you should suspect retrograde ejaculation. So how do we check to confirm is for you to get the post-ejaculation or post-orgasmic urine. So you ask the patient to pee first, and then ask them to masturbate, produce, ejaculate, and then ask the patient to pee again so that you will get the sperm inside the urine. And if the sperm is to be utilized for ART or ICSI procedure, you must make sure that the urine is alkalinized, because the sperm cannot survive in acidic environment of the urine. So that's how you confirm and get the sperm.
Okay, the third question from Abidah Abdullah. I have a 31 years old couple trying to get pregnant for more than 1 year. However, the husband has retarded ejaculation, which causing delay in ejaculation. Sometimes cannot ejaculate at all. Already under Euroteam, however, symptoms not improve despite on medication. Is there any role of infertility treatment that can help this couple? Thank you.
Okay, obviously there is. If there is problem with ejaculation, first we will look at the factors that lead to abnormal ejaculatory problem. For example, if the patient is having diabetes, so we optimize the diabetic or sugar control of the patient. So if the patient cannot ejaculate, what we can do is we can retrieve the sperm, providing that the sperm production is normal by looking at the hormonal level and also the testicular size. So what we can do is we can subject them for surgical sperm retrieval, as I mentioned before, PESA or TC, and proceeded with ICSI.
Okay, can you share the slides on sperm micronutrients again? And then we take a last question from Zubaida. Okay, how to explain to couple with SFA reported as not liquefied after 2 hours, and what is the treatment?
Okay, so as I said, the seminal fluid should be able to liquefy within 35 minutes. So if there is a problem, usually there will be problem with the secretory ducts of the patients. So, but that is not a big problem. Because we can add some fluid or some products to liquefy the sperm and proceed with the assessment of the count, morphology, and motility. We just need to take note that the patient, the sperm is unable to liquefy after 2 hours. As long as we can get the important parameters, we can still proceed with treatment.
Alright, okay, thank you very much everybody. I think that's the end of the session.
Okay. Thank you.
Hand over back to Dr. Kok.